So my case is a rare case of seronegative immune-mediated necrotizing myopathy that manifested as dysphagia and elevated transaminases that I saw on floor. So essentially, I'm going to start with introduction. So immune-mediated necrotizing myopathies, there are subtypes of autoimmune muscle disease that typically manifest as severe subacute proximal muscle weakness and marked elevated serum kinase, as well as in histology, you typically find myofiber necrosis or absence inflammatory cells, um, absence or sometimes even like minimal inflammatory cell infiltrates on muscle biopsy. So then in trying to kind of categorize this disease, the seronegative is part of this group, and you have three of them. You have the anti-HMG-CR antibodies, and you have the anti-signal recognition pathway, that's the SRP as well. So seronegative is the least studied and least common. So which was really interesting for us when we saw this case. And typically for the seronegative as well, they don't manifest commonly as dysphagia. They just manifest as extramuscular, they manifest as muscular pathology. So this was pretty interesting when we had this extramuscular activity where the patient manifested principally as dysphagia with associated myopathy and all the accompanying symptoms. So on the case description, the patient was a 37-year-old guy, has no past medical history, went to urgent care initially for dysphagia and was diagnosed with uh, a possible strep and started on treatment. However, his symptoms worsened with worsening fatigue, exertional dyspnea, reduced urine output, and nausea, vomiting, generalized myalgia, necessitating his presentation to ER. Then upon admission, we did a comprehensive diagnostic workup for him, including CBC, CMP, creatine kinase urinalysis, also got rapid strep just to confirm, and mononucleosis as well. Essentially, numbers were remarkably high in terms of like creatine kinase was over 200,000. That was my first time seeing that amount of elevation. His hepatic enzymes were also elevated. Aspartate was 1024, then alanine transaminase was 174. His creatinine was uptrending by the day. He came in with 6 by the time it was day 2. He was already in 8, 9, requiring renal replacement therapy. Other things were his UA was also abnormal, 4+ protein. We decided to get an acute glomerulonephritis workup for him, including ASO titers, anti-DNA, ANCA, hepatitis serologies as well, B and C. Everything was essentially normal. We got a CT as well. There were no malignancies seen on CT because we also had in mind that this myopathy could be like related to like the polymyositis in general, but there was no malignancy at that point. But his symptoms worsened. Then we decided to get more workup, autoimmune panel, myositis panel. We got GI involved, got an MBS on him, Barren swallow as well. Nothing was revealing at that point. However, the autoimmune did pick up weak positive C ANCA, but at that time we didn't really make anything out of it because it wasn't really classic. We're not suspecting like vasculitis at that time. So we decided to get a muscle biopsy. But at the same time, because we had high index of suspicion that something inflammatory is possibly going on, we started him on high-dose IV methylprednisolone, which he actually started responding to by day 4, day 5, while also getting aggressive hydration for his rhabdo at that time, as well as renal replacement therapies. Then days following, biopsies came back positive for necrotizing myopathy. And meanwhile, like looking at the autoimmune panel, it was negative for anti-HMG-CR, which you will typically will look out for an anti-SRP. So that kind of gave us like a conclusive diagnosis of seronegative immune-mediated necrotizing myopathy. If you look below, is a picture of the slides. The first one is just highlighting the necrotic muscle. The one below is just showing you the inflammatory the infiltrates on the muscle biopsies. So, but remember that I mentioned earlier that we don't commonly see inflammatory cells. So this was also, a little bit different from what we typically see, even considering his age and his gender, because commonly we'll see that happen for we have common predominance for women as well as people aged 40 to 50. So his was particularly a unique and different case. So just to kind of tie up things, uh, it's seronegative immune-mediated necrotizing myopathy is essentially a very rare condition and under-researched as well. So, and presentation almost most of the time atypical. So just maintaining high index of suspicion, especially when we see patients coming in with elevated creatine kinase, dysphagia, and muscular symptoms like generalized weakness, myopathies, myalgia, and all the rest. Also, just to also mention that having a negative anti-SRP and anti-HMGs antibodies, which we will typically see for patients that have static myopathy, having that negative doesn't rule out this pathology. And finally, making your diagnosis of this condition is only by muscle biopsy.